Hi, everybody. My name is Claire Kreutzfeld. I'm the secretary and one of the founding officers of the INPCS, as well as a co-director of the INPCS Research Committee. It is my honor to introduce you to a transformative figure in neuropalliative care and present the INPCS Lifetime Achievement Award to Dr. Kathleen Foley. Dr. Foley is a neurologist who was instrumental in getting palliative care and neuropalliative care to where they are now. Dr. Foley trained at Memorial Sloan Kettering Cancer Center, where she founded the new pain consult service in 1981. This was at a time when pain came with the cancer, but wasn't really talked about, especially by physicians. Now it's one of our vital signs. Dr. Foley also founded and ran the project on death and dying in America, PDIA, that developed those people that we all now know as leaders in palliative care. Her tireless efforts continue, with a focus now on developing pain and palliative care initiatives globally and working closely with the WHO. So we are really excited to hear her speak to us today about access to neuropalliative care, a human rights and public health challenge. Thank you, Kathy.
My special thanks to the International Neuropalliative Care Society for this award. It's really an honor to give this brief talk and to continue my advocacy for advancing palliative care both locally and globally. I think neurologists are the best clinicians to provide palliative care. They're trained in good history taking, in defining the lesion by a medical exam. They know how to use technology to better define a diagnosis. And they're trained in psychiatry, understanding the distinctions between pain and suffering. And they have a lot of experience in caring for patients with chronic, incurable illnesses. So I trained as a neuro-oncologist and studied cancer patients with pain. Their neurological complications of cancer were the real focus of my clinical and academic work. At Memorial Sloan Kettering Cancer Center, within the Department of Neurology, we developed an active research program. It was to assess and treat patients with pain, to study opioid analgesics in both adults and children. I did this clinical work for about 20 years, and then partially changed my career direction to become the director and medical director of a US-based and then an international foundation effort to improve the care of the dying and to advance palliative care globally. And I've done this for about the last 25 years. Today, my focus on what neurologists need to know about public health and human rights to advance the field of neuropalliative care is really to focus on what we need to do to make it a sustainable clinical and academic field. So I apologize to all of you for this narrow focus, but it's one that I think needs much more attention if our goal is to make universal health coverage a reality and palliative care, both a public health and a human rights issue. We have this growing evidence base to show the effectiveness of palliative care. And we have a specific evidence in neurology of the impact of palliative care interventions. So now we need to advocate for healthcare reform to healthcare funders to incorporate palliative care into national health schemes and into payment systems. So with that, I was going to take you through this story of access to neuropalliative care from a human rights and public health challenge, with the hope that some of this information might be useful as at a country level you begin to develop your palliative care programs. So let me now take you into a discussion, and let me begin with my conflict of interest. I'm a trustee for the Cecily Saunders Institute. I'm a medical advisor for the Rita Allen Foundation, and I'm a member at Physicians for Human Rights. So what do I mean by palliative care as a public health issue? Well, clearly it affects all people. Everyone will have a end-of-life period of time, and in that experience will require and need good palliative care. There's clearly a need for better information on end-of-life care, and we have innumerable studies that have demonstrated the lack of information that patients and families have in understanding what happens as they face a serious and life-threatening illness. Palliative care within the public health domain offers the potential to prevent suffering, and I'll come back to this, and also the potential to prevent disease. And what I mean as palliative care as a prevention model, which is really very critical to anything that represents a public health need, is that it has this extraordinary opportunity to prevent needless suffering for people with overwhelming symptoms that could be managed that are not managed, for individuals with overwhelming suffering that could be addressed by appropriate medical care and by appropriate symptom control. We also know that palliative care is a peer education approach, and probably we learn this best in the AIDS epidemic and also in the treatment of MDR-TB, where the opportunity for home community workers to provide care to individuals with those diseases were able to also teach the family members about the need for public health standards and care within those communities. Palliative care clearly is a patient-centered care model within this public health framework, and it incorporates so many approaches to self-management programs that gives people the opportunity to understand what their illness is, to understand its management, and to make informed decisions about how they view their end-of-life care, the choices that they would like, and the kinds of decisions they would like to make. So here's an example of a cancer control document on palliative care that was put forth by the World Health Organization. And it very clearly defined what we call as this WHO public health model for palliative care. Obviously, the context makes a difference. So if we're talking about the development of palliative care in a high resource country like the US, it's different in a way than the development at a lower middle income country. Also, the outcomes will be quite distinct and related to the context. But what is critically important is that there are a series of elements that are essential. There needs to be an umbrella policy that focuses on and supports palliative care. And within it, it needs this triangle of medicine availability. So the essential medicines that we need to be able to provide good symptom relief. For the in neurology, clearly anti-seizure medicines are part of that essential medicine list, but it's the use of and availability of analgesic drugs, the availability of drugs to control confusional states, the availability of drugs to control and address fatigue, shortness of breath, and on and on. And at the same time, there's such an extraordinary need for education. And it's not simply the education of healthcare professionals, but it's the education of the public. And lastly, part of this triangle is the need for both research and implementation that's done at a local level and then done at a more general and global level. And this is what we call this WHO public health model. So as we go into a country and assess whether they're developing palliative care, you want to make sure you have these essential components to be called a public health program. And the policy piece, as I identified, is so critically important. And here I think is a great reference that was put together by Xavier Gomez-Baptiste, who is a palliative care physician and a geriatrician who's led a major efforts in Barcelona. And Stephen Connor, who is the head of the Worldwide Hospice and Palliative Care Organization. And this is really a great outline of different ways of building integrated palliative care programs and services. So coming back to the area that I'm most familiar with, the global cancer mortality, the reason why palliative care became so critically important in the cancer arena was the fact that many patients who presented with cancer, and as you see, 8 million die per year from cancer, with about 12.7 million people diagnosed each year with cancer. The numbers are staggering, and there was extraordinary need to be able to provide services for those patients who presented with very advanced disease, who had no opportunity or no resource to receive care. And clearly the critically important need to control symptoms and quality of life for the 29 million cancer survivors. So clearly the cancer population has been the focus of the development of the field of palliative care. But as we're well aware, there are so many other patients who need such care. And that's why there's been increasing evidence to support the need for us to better understand the global need for palliative care. So these are two different studies, one representing on the left the Global Atlas of Palliative Care, again put together by the World World Hospice and Palliative Care Organization and Stephen Connor. And they estimated that about 56.8 million people require palliative care in general. And this would be about 31.1 million prior to their end of life and about 25.7 million who are dying. And in this global atlas, they used pain as a surrogate for the need for palliative care. Moving forward from that, and more recently, the Lancet Commission report on pain and palliative care estimated the numbers that have a need for palliative care at about 25.6 million. They increased their total need for palliative care for those who were living in the last days of their lives to about 61.1 million, and 5 million of those are children. And what they used then was suffering, and a term called health-related suffering that I'll come back to, as a surrogate, and developed a really nice way and a metric of measuring and assessing serious health-related suffering as a metric to be able to look at the global need for palliative care. But however we look at it, the needs are enormous. And this is the cover of the Lancet article. What I think is particularly important is that this is a group who in 2017 published this really extensive report. But coming forth from that extensive report was the coming together of economists, of public health experts, of palliative care clinicians who work very much together to come forth with this report. And I think what, if nothing else, I've learned from participating in this effort was the need that we, in our own specialty fields, need to branch out to our economist friends and our public health friends to be able to help us impact how we advance palliative care globally. So what the Lancet Commission report did in estimating the global, what's called the global burden of health-related suffering, was they used the ICD-10, and they identified decedents as patients with health-related suffering with one of a variety of conditions. I'll show you that in a moment. And then non-decedents for those who had health-related suffering with one of the conditions, but did not die in that year. And the year of these studies was 2015. And those who worked on this quite significantly were Eric Krakauer in the group and Dean Jameson. And we owe an enormous amount of credit to their efforts to do this work. So here are the conditions that generated the issues related to who were our decedents and non-decedents. I'm not taking you through this incredible list, but only to point out that if you see dementia, F004, if you look at cerebrovascular disease, as you look at congenital malformations, musculoskeletal disorders, patients with neurologic disease make up a large number of individuals who need palliative care. And again, we need to be able to estimate this number so that we can provide to governments an appropriate assessment for them to determine what services could be and should be provided. And then we need to help describe what those services are. And the four categories and the specific types of suffering were classed under physical, psychological, social, and spiritual. And as you see, this is a pretty elaborate list of the common physical, psychological, social, and spiritual symptoms individuals would experience. And then with the categories and the specific types of sufferings, then with the prevalence of each type of suffering, then with the duration of each type of suffering. And this took an enormous amount of work. And again, Eric Krakauer led much of this effort. And the estimates of how these numbers came to be was based on a thorough literature review, and then a review that was adjusted by a panel of experienced palliative care clinicians working in low and middle income countries. So this was an extensive body of effort. But coming out of it came to be this metric for assessing the need for palliative care, which is called serious health-related suffering. And so this, I think, has moved the field forward because now there are a variety of authors, including more recently, Catherine Sleeman at the Cecily Saunders Institute, who's done further studies to assess the needs for palliative care. And she's mapped out studies to 2060, looking at the need for palliative care. And without question, in her studies that have been recently published, it shows the extraordinary need for neuropalliative care. And so with this serious health-related suffering metric, one can then create a package of services, a package that has essential medicines included, and a package that includes the staff. And for each of these, there's cost accounting that our healthcare economists have helped us do. So we can look at palliative care in the home, in the hospital, in the community setting. We can look at the medicine list, which is an essential drug list plus other important medicines. And then we can look at the staffing. And this is critically important because coming up with this data, it suggests that the cost for palliative care in a budget of a country is anywhere from like 0.6 to maybe 3% of their annual healthcare budget. So it is not an enormous burden on the healthcare budget. And there's every evidence to suggest that providing such services have the potential to improve care for the individuals and also to provide cost saving. So again, the future studies will be taking these metrics and applying them in clinical situations in countries and assessing the outcomes of those. And so, for example, in countries where there's been universal health coverage that has already been integrated into the government and palliative care, Mexico has been one example. They've developed a national palliative care policy. They've made oral morphine available. And in each district, they have palliative care services that meet this serious health-related suffering metric or use this metric and have developed costs for these services. And in Rwanda, which also has a national palliative care policy, has been planning and has been scaling up a variety of pilot projects. And that data is now becoming evidence to look to see what is the financial impact of providing these services. And most importantly, what is the cost serving aspects of this? So what are the challenges and visions for palliative care if we talk about it in this public health domain? Well, clearly, there's a need for public financing for palliative care to be extended in so many lower and middle income countries. Clearly, even in the United States, we have a long way to go. Palliative care is included in countries' universal health coverage scheme in some countries, but the hope is that we could push this forward with advocacy around universal health coverage to include it by 2030. And using palliative care indicators and evidence, we can measure the impact and values in these healthcare systems, again, to demonstrate the potential for its effectiveness, as well as ability to provide potential cost savings, but without question, better quality of care. So that's how we're using this palliative care public health agenda to be able to influence how palliative care is integrated into healthcare systems. So now I'm going to switch, which is not much of a short shift, into the concept of palliative care as a human right. So the language for pain relief and palliative care has been long embedded in human rights conventions. I think nothing that we've done in the last 15 years have dramatically changed the construct that patients, that in the human rights conventions, that there is a need for palliative care if it was not well acknowledged. There are multiple conventions that support a right to palliative care, and I'll give you examples of those. And clearly, the concept of access to essential medicines is contained within the right to the highest attainable standard of care, basically the right to health. So in 2010, the World Health Assembly, in its resolution on cancer, did include the language of palliative care and argued that in any country where cancer programs were being developed, that the countries needed to pay attention to not simply prevention and treatment, but also to palliative care. In 2012, the UN resolution on universal health care included the language of palliative care and made palliative care, cited palliative care as in need of receiving universal health care coverage. In 2012 as well, the WHO resolution on non-communicable disease also includes palliative care. And then probably most important, in 2014, the World Health Assembly's resolution on palliative care. And this was a resolution that was critically important. It was passed in 2014, and it was the strengthening of palliative care as a component of integrated treatment within the continuum of care. And this resolution was put together by our human rights advocates, by our public health advocates, by many of our colleagues in low and middle income countries who spoke to and argued for the need for the World Health Organization to recognize palliative care as both a public health issue and as a human rights issue. So what are the conventions? So I'm going to start with those of the child. You're probably all well familiar with these. There's the UN Convention on the Rights of the Child, which was ratified by 194 countries, even though the US has not ratified it. There are country reviews, so it's an opportunity in those reviews to bring up the topic of palliative care. There's an opportunity also to complain that different countries are not meeting the UN Convention. And in those countries where palliative care is not available for children, there's been opportunities to be able to lodge complaints related to the lack of palliative care for children. But in the UN Convention on the Rights of the Child, there's a series of articles that clearly can be interpreted to be most important for access to palliative care, including the right to non-discrimination, the right to survival and development. So they would have access to approaches and care that would improve their quality of life. The right to be heard and to be part of decision-making for children with serious illness and the various choices that are made in their care. Their right to a full and decent life and their right to care and their right to essential medicines and their right to pain relief. And lastly, the right to the highest attainable standard of care in Article 24. So clearly well embedded in the UN Convention on the Rights of the Child, our human rights colleagues have defined how palliative care is clearly there in its appropriate language. And a group called the Foundation, the Maruzza Foundation, an Italian foundation dedicated to the rights of children with serious illness and to the development of palliative care, created a civil society initiative, this charter, which was really one of the first documents to set standards in this area. So again, I refer you to this for children with neurologic illness to be able to advocate for their palliative care. And this is a wonderful video that's available on YouTube and available at this website called Little Stars. It is a story of a variety of children and their families with advanced illness and the need for palliative care. And lastly, in this construct of a human rights dimension, the Religions of the World Charter for Children's Palliative Care was put together by the Palliative Care Initiative at the Vatican. And this was a meeting supported by the Maruzza Foundation, but looked at and brought together religions of the world who could support the need for children's palliative care. And it's a wonderful document. I'm glad to share it with you. It's been published, where it puts forth what is critically important for children and for their need, and how we might use this to be able to advocate more strongly for palliative care for children. And in fact, the Vatican in its Palliative Care Academy has put forth strong arguments for the rights for children to receive palliative care. So there's a lot building on this in a human rights religious perspective. If we go to the adult perspective, it's the International Convention on Economic, Social, and Cultural Rights, which you probably know well, is where palliative care is a recognized component of the right to the highest attainable standard of care. So this is heavily and clearly embedded in that document. And then in a 2015 document, which was focused on the rights of the older person, there was a great deal of advocacy by our geriatric colleagues to begin to, in this treaty, which is an inter-American treaty, to explicitly refer to palliative care in multiple sections. And so elaborately through this document is referral of palliative care for our geriatric population. And in the International Convention on Civil and Political Rights, which prohibits torture, inhuman, and degrading treatment, there was clear attention to beginning to look at this lack of pain relief as a form of torture. And so, in a wonderful publication that was put forth by the Special Rapporteur on Torture, in a report that he did in 2013, and for which we submitted evidence to this report, he strongly argued that the de facto denial of access to pain relief, if it causes severe pain and suffering, constitutes cruel, inhuman, or degrading treatment. And I think there are many of my colleagues that have thought that calling lack of treatment of pain of torture was going slightly over the line. But I think this document outlines how this can be seen as a form of torture when there are available medications that could ease the pain and the access is not given to them in individual countries. So pain treatment clearly as a human rights issue and as part of a right to health has been a critically important aspect, since pain is a common symptom in patients, at least with cancer at the end of life, and in a majority of individuals with a range of medical illnesses. So what is this and how does this become a human right? Well, opioids are considered essential medicines, and countries have signed on to an essential medicine list that the WHO has propagated. So they need to provide these essential medicines as a core obligation under the right to health. States are required to put in place an effective procurement and distribution system. They need to create a legal and a regulatory framework. They need to allow healthcare professionals to prescribe and dispense after they're effectively trained. And the drugs don't have to be free, but they need to be affordable. And all of this needs to occur, and this is really very carefully in detail discussed in the Lancet paper, that they have to be provided in a balanced drug policy perspective, where the risk associated with these medications are looked at carefully, but that the systems in place are framed to be able to provide these essential medicines to those who need them. And what came out of the Lancet report was this particular schematic, which has been put together by data that we have from a variety of different sources that look at the availability of opioids globally. As you see on the slide, the most insidious injustice to our public health colleagues who had not recognized this was this lack of availability of strong medications for patients. They look specifically at patients with cancer or HIV/AIDS, but we could look at this in a much larger population and seeing the incredible disparities of large supplies of these medications available in high-resource countries, but not available in the rest of the world. And yet, 90% of the people who might require these medications live in low and middle income countries. But again, our public health colleagues called attention to this as an incredible injustice. And our human rights colleagues called attention to this, causing this and calling this a form of torture. So taking the pain relief and palliative care perspective to the expertise of human rights advocates, we worked closely with Human Rights Watch, who issued a series of reports in India looking at the issue of the lack of availability of palliative care, and then in a variety of countries looking at both the lack of available pain medications as well as the lack of availability of palliative care. And so I won't belabor this with you, it's just some examples. India has clearly an obligation to ensure availability of palliative care. And in this very, very thorough report with really quite compelling videos, the issues related to the access to appropriate pain medicine, access to palliative care services is well described. And based on this document and with the incredible advocacy of our Indian colleagues, led by Dr. Raj Gopal and others, there's been what is called Pallium India. We've seen incredible advances in the availability of palliative care services and the availability of oral opioids to treat those patients in pain. So this was some of the early days of the compelling reports of that were blaming and shaming to call attention to the lack of human rights available to Indian citizens. In a more global report, the Human Rights Watch looked at access to pain treatment as a human right. In this particular document, pointed out how countries could significantly improve access to pain medications by addressing the causes of their poor availability. These tended to be a failure to put in place functional supply and distribution systems. There was an absence of government policies to assure their availability. There was insufficient instruction of healthcare workers. There were excessively strict drug control regulations, and there was fear of legal sanctions among healthcare workers. And this is a government responsibility to provide access to pain treatment as part of a right to a humane standard of health. And so I think, again, points out the importance of helping the help from our human rights colleagues to be able to point out the human rights dimensions of this lack of treatment. In Kenya, this particular report called Needless Pain pointed to the government's failure to provide palliative care for children in Kenya. And these are children with serious life-threatening illnesses, including HIV and cancer was probably the lead, but a variety of different conditions, and the lack of the government to provide appropriate resources. The Kenyan government did not like this report. They were rather embarrassed by it and annoyed by it, but with the wonderful efforts of Dr. Zipporah Ali and the development of the Kenyan Hospice and Palliative Care Association, there's been an incredible move forward to expand palliative care within Kenya. And lastly, this work in Ukraine before the war by our colleagues at the Soros Foundation in Ukraine, who identified the fact that within Ukraine, there were very, very strict rules that set the amount of morphine that could be given to any patient at 50 milligrams of injectable morphine a day. There was no access to oral morphine within the country. And so what patients and families had available to them, what physicians could prescribe, was no more than injectable morphine and no more on a daily basis than 50 milligrams a day. And this led to the data that shows how Ukraine had a very minimal, as you can see, per capita income of morphine use, not unlike other countries in the region. So I don't want to suggest that Ukraine was unique in that, but compared to developed countries, this was quite significant and low. And this translated into what became a campaign called Stop Torture in Healthcare, and led eventually to the Novak report on torture in healthcare and pain relief as a component of that. So what was reported was that really people within Ukraine who had debilitating illnesses like this young man, Vlad, were left to die in excruciating pain because there were restrictions on pain medicines. And healthcare workers were not allowed to provide patients with relief for pain. So Vlad was this incredibly lovely young man who was willing to be part of this video, in which he had all of the appropriate resources for palliative care, in that he had wonderful caregivers. His mother provided care to him. He had good friends who came. He had social supports. He had food. He lived in a small apartment with his mother, but was comfortable. But what he didn't have was effective pain relief. And he had significant neuropathic pain associated with a leptomeningeal disease that was infiltrating his lumbar and sacral plexus, leaving him partially paralyzed and also leaving him with significant disability. So it was in this setting, in the story of Vlad, we called attention to torture in healthcare. And the video was eventually played on national television in Ukraine with a great deal of advocacy around that by the Hospice and Palliative Care Association of Ukraine, moving the government to be rather embarrassed by this lack of availability of appropriate compassionate care for its citizens, and moving eventually to provide access to oral morphine for patients. Vlad did not benefit from that long-term effect, but he clearly was an incredibly important advocate in using the language of torture in healthcare as a way of beginning to convince governments of the need for policy. So let me close by focusing on the fact that using both public health information and using a human rights perspective are ways that we can move forward to advance palliative care. And this is not in any way to suggest that we should stop assuming and creating the evidence base that we need, which is really critical. But with this critical evidence base, we know that we need to have other levels to affect policy. And so as we look at what the policies might be necessary, we know that we need to have governments recognize that they have a responsibility to provide essential medicines, to provide access to care, to provide a high standard of care, and that palliative care fits within this. And so for those patients with neurologic injury, who themselves have often significant disabilities, framing this in both the human rights language and a public health language, I think can be a much more powerful way than us simply talking to the government and saying we know what the evidence base is. So our experience has been in working with our colleagues in public health and human rights is to engage them in our advocacy for advancing palliative care. So I hope some of this is useful. I'll gladly provide you with all the references related to this work and to how you might be able to use it in individual countries. And again, thank you so much to the International Neuropalliative Care Society for the opportunity to give this talk and for the award. And good luck to all of you who are working in this field. I'm in great awe of your efforts, and I know you can make a difference. So thank you.
Thank you. Thank you so much, Kathy. And thank you for all your work with this. I understand that Kathy is in Florida right now, and so is having some challenges, but is actually able to be here with us, which is wonderful, but I think we won't be able to see her. Kathy, I really like this idea of suffering as a surrogate to assess palliative care need. And I think maybe one of our next challenges is to assess health-related suffering specific to neurological disorders. Do you have any ideas on how we might do that?
Oh, yeah, I think, can you hear me? I think it would be incredibly important to do that. And in fact, in the original Lancet paper, Eric Krakauer sort of detailed a methodology that people could use. And so Eric would be willing to help anyone who'd like to do this. But he did choose some neurologic diseases. He looked at stroke, he looked at epilepsy. And I think that there's a real opportunity to tease this apart and to put together exactly the statistics that we need that's related to it. So it's quite, it requires a really good statistician, and it requires a panel to put together what are the symptoms, what are the current treatments, what's available in the country, how long would people take it. So there's lots of prognostication and estimates, but it's a methodology that's been quite respected and led by economists like Dean Jameson, who helped Eric with this work, by Felicia Knoll as well. And I think it's such an example of engaging the economists and the health economists, because when Dean Jameson came into this topic, he was joking with us about the quality of, the way the WHO estimates the quality of life in life years, et cetera. And he said, well, should we do it in quality in life in hours or minutes or seconds? And out of all that discussion came this serious health-related suffering. So it's a well-respected measure. It's a metric going to be used. It's a methodology available. So I absolutely would encourage that for each neurologic disease in a variety of countries, we begin to assess it. And I think if we do it, and once it's done in a couple of countries, I think it will be very possible for those countries to then take that methodology to their own countries. So yes, it's really important, because if we can't measure it, the governments won't pay for it.
Exactly. And sort of thinking about, those four relatively established categories of suffering. And I imagine, physical suffering is easier to measure than spiritual or psychological or even social.
Absolutely. And probably the hardest was the perspective of spiritual. But again, there are a variety of measures that can be used. But the probably the most, at the present time, for the physical, one can measure symptoms. For the psychological, again, one can measure specific symptoms and ICD diagnoses if necessary. And then for the spiritual, there it's a little bit more complicated, but there's clearly a diagnostic criteria and scales that we can use. The important piece is that, at least for the physical and psychological, and within the physical is the kind of equipment people would need. So what are the bare essentials that a person, let's say with motor neuron disease, would need to have to be able to be cared for in a palliative care setting? What are the essentials that a child with a muscular dystrophy, what are the bare physical needs that a family would need to have to be able to provide care for that, a wheelchair or crutches or a variety of different devices. So it includes those kinds of calculations as well. And I think, good, smart people can sit together and make up these numbers and put them together. And clearly they're estimates, but it gives the government an understanding of what the potential costs are. And in doing this, the costs are not that high compared to not doing it. And compared to relying on then families and others to do the caring of the individual, to do the caretaking of the individual. So there's a real advantage for using this kind of methodology to assess what the parameters of care are.
Great, thank you. I have a question from the audience. What do you see as the top international priorities for neuropalliative care?
I think it's getting paid to do it. So it's understanding the economics, because I think there are really smart neurologists out there who are able and have developed a beginning evidence base, and there's a significant evidence base in palliative care in general. So I think the next step is that for any of this to survive and to grow and to be sustainable, those neurologists seeing those patients have to be paid to do this, and the nurses and the social workers and the psychologists that work in these teams also have to be supported. So we have to be able to understand at an international, what does this cost, to be able to say to the governments, this is the bare essential package, because governments are now clearly moving to universal health care. And within this universal health care, they see that these are groups that they have to address. If we don't have those numbers, if we're not at the table, we're not going to be, it's not going to be addressed. And it's not to say that the neurologists and the palliative care people should be stepping out from, pediatrics or geriatrics. But I think within there, carving out what are the special needs of these populations and creating easily available methods to be able to assess the cost of these cares and to be able to then demand that they're paid for, because these individuals have a human right to it. So if you have what the costs are, you can then go to our human rights colleagues and say, listen, this is a government responsibility. You need to be able to assess the pay for this, because we've assessed it and this is what we know the costs are. So our work clearly, I think probably in some countries, Mexico is the best example. They have universal health care. They had no way to begin to assess what they were doing in palliative care for cancer patients. And once they began to have an understanding of what the finances were, which were not overwhelming, they were quite willing to include it in the government policies. So it requires us moving out from our field of neurology to be working within this, interprofessional, multi-professional expertise beyond us. And be assured, I am in no way minimizing how critical the evidence base of what we do is necessary, but I think there's a lot of good evidence out there. I think that we haven't moved it forward in an advocacy fashion.
And I think you and I have had a conversation before of, I think what's especially important in lower income countries is to ensure that palliative care is provided concurrent with the best,
right,
like evidence-based neurologic care.
Absolutely, right. None of this should be separate. Palliative care should be part of the fully integrated care system. And so by defining it as palliative care, and by giving it that name, for which many people will argue that it should be called supportive care or this or that, and we've argued a lot. I'm sticking with the palliative care name simply because we have so much documentation at the World Health Organization in the language of palliative care. And I think patients and families can begin to understand that. But it needs to be fully integrated. It has to be part of the continuum of care. It has to be part of the WHO diagram that we care for patients over time. And some patients, palliative care will begin at the minute of diagnosis till the end. For other patients, it will come in at different times. But at the and toward those patients with serious life-limiting illnesses, there's an extraordinary need for the level of expertise, and clearly every neurologist should have basic palliative care skills, but we will need specialist palliative care neurologists as well to be able to teach those the primary skills. So I think we need specialists as well as primary care, but and we need to be able to fund those individuals doing that work to be able to do that work. This should not be kindness or compassion. These patients have a right to it, and the government should be paying for it. And we just have to figure out how to match that up. And it will only happen with patients and families coming together with the palliative care groups to be able to advocate for.
I have another question for you from the audience. With the focus in palliative care being traditionally tied to cancer, are
Yes.
there disparities for non-cancer and specifically neurologic illnesses? And if so, how do we go about advocating for expanding palliative care to neurological illnesses?
Yeah, I would hope there, yes, the tradition has been in cancer because cancer was seen as the fatal disease. And in low and income countries, predominantly, if patients had a diagnosis of cancer, then they were likely to die of that disease because there was no treatment. And for neurologic diseases, I think we need to argue for the fact that these are chronic illnesses over a period of time that require very sophisticated symptom management, that require a variety of rehabilitation components, and that by using the language of palliative care and helping to define what is palliative care within the neurologic population, and having everyone agree, which in fact the society is doing that, that using that as a focus is a way to be able to teach the public about what are the advantages and what is palliative care. So I think that the burden, and be assured it's still not fully done in the cancer world, although maybe more accepted from a policy perspective. But I think what we need to do is have a public conversation with a variety of different organizations that advocate for disease treatments as to what is palliative care and how patients from ALS would benefit from palliative care, how patients with neurodegenerative disease and Alzheimer's disease. And this is happening. I mean, this is each of the groups now have, palliative care components. I think we just have to do more and more and more of that. It's a profound public education campaign to say this is so that for a patient with a neurologic illness who has advanced ALS, my perspective would be, are you getting palliative care? And if they're not, then they're not getting quality care. So this is an indicator of quality care. So the advocacy, it's quality care. The dimension is public education. So we have a lot of education in the high resource countries like the US, but in our low and income countries about what is palliative care. And we never want palliative care to be seen as second class care or no care. We need to be arguing strongly that this is concurrent with the best of medical care available to patients.
Yes, I have another question from the audience. Can we operationalize the methods for this to calculate suffering at a regional level to assist local service development?
Yes. So I think we have examples. We've worked with colleagues, a variety of places to do this. And so we've worked in parts of Romania as an example. Regional hospices got together and figured out what their costs were, provided that to the government.
Ooh, have we lost Kathy? I think Florida just kicked Kathy out of the internet. Sure, and Benzi, why don't you join us for just a few more minutes? I think this is a fascinating conversation. I was thinking a little bit about that challenge that palliative care used to be associated with death. And so cancer also was associated with death. And now we're just a step forward where we're saying palliative care is not only for the dying, and also neurological illness or a neurological diagnosis doesn't immediately associate with death.
Yeah, well, I think I love the talk, and it looks like Kathy is back, so I will step out again. But I think it's really, really inspiring, and I think the focus on suffering and the focus on, not just on death, as you say, but really quantifying suffering and then using that data to argue for the essential role of palliative care for neurologic patients, for their families, and for others it's just a really cool framework. So I'm been furiously taking notes and want to have some follow-up conversations with Dr. Foley, because yeah, it's been very, very eye-opening for me to see this and think about it on this scale and with this lens.
Yeah, Kathy.
Yes, can you hear me?
Yes, thank you for being back. It's just so wonderful to have you. And we were talking again about this concept of suffering and maybe I think people are using palliative care, or a new definition of palliative care is to treat suffering, treat and prevent.
Right. Yeah. Yes, and it is to prevent needless suffering. So I think remember that. So and it's, you know, the term is serious health related suffering. So that's the language of the economists that they have put together for us. And so what is serious health related suffering? And how we define that. And there's a clear outline before that we begin to address. But again, it's interesting to talk about suffering because it means many different things to many different people. And that's why keeping it as serious health related suffering as that terminology is how we're using it as an economic term, as a metric term, I guess is a better way to say it. So a metric term to define the economics of care.
And you use the word economic because that's how you have to advocate to health systems and countries.
Yes, when the Lancet Committee met, the purpose was to figure out and to try to put forth a commission report with public health experts and economists telling us palliative care people what we had to do to move the field forward. So I'm just suggesting that we neurologists, to move the field forward, need to incorporate this methodology in our assessment of our disease, our patients with these diseases, to be able to come up with an economic model that's acceptable to governments that will make this type of care sustainable.
I have a follow-up question from the audience. The government argues that we don't have the workforce to support widespread access to palliative care. How do we respond to that?
Exactly. So we don't have the workforce, but we won't have the workforce if we don't start asking for it. So it's a circular argument. So we start building up the workforce, but the government will say they don't have the workforce because they don't even know what the workforce is. They don't know that you need a social worker, you need a community nurse, that the different players. But when each of those, so in various countries in Central and Eastern Europe, where I worked with from the funds from the Soros Foundation, we would at a country, literally at a community level, define the roles of these individuals and be able to show that the government would often have to change their policies to allow volunteers to be able to see patients and help out, to allow social workers to make home visits, to allow doctors to make home visits. I mean, we're in the weeds on these policies, but the point I'm coming to is that to be able to advance palliative care in a range of different countries, one has to be quite in the weeds of what and how care is delivered in those countries. So in each country, we need to be quite respectful of the systems that are in place and how to access those systems. But everyone, the WHO including, is agreeing that we have a metric that we could use. And this is the serious health-related suffering. So it's worth our using it to come up with different categories of what workers are necessary. And then have included in that, what would it cost to train those workers? And so that would be part of the budget going forward. How the nursing schools would have to develop training initiatives, how the medical schools would develop training initiatives. So this is, it's a large effort, but again, it begins small with champions in each country, leading those efforts in their countries. And there's so many extraordinary champions that I know in so many different countries that are working so hard. So, I see it as possible, and it may take 20 years, but it'll get there.
I just got one more question. Let's see if we can fit it into our last 25 seconds, Kathy. What do you see as the role of neurologists in both advocacy and providing palliative care? So mostly primary palliative care then.
Well, I mean, they're just like so important. You know, I'm a neurologist, obviously, so I'm the advocate for the field. But I think the important thing about neurologists is we understand the diseases that these people have, and we know how to diagnose these diseases. And we also understand how to communicate about these diseases with patients over a period of time. We're used to taking care of people with chronic illnesses that often are incurable. So we already have that level of expertise and that kind of drive to think that we still should care for them and we should respect them. So I think the neurologists can just be the leaders in this, and in so many ways, and in many places they are. So I think that I see a critically important role in the neurologist taking care of patients with serious chronic illness, and doing the best to be able to provide them with high quality, evidence-based, economically supported palliative care.
Like you certainly have, and it's just amazing to see all your work. So thank you again. Thank you so much for your work and for your wonderful talk today, Kathy, and for making it despite the weather around you and talking to us.
Okay, great. Thanks so much.